Okay, let me just say a few words before we start. This is a topic, the organ shortage in the United States. I don't know how familiar people are with this subject. It's a subject that everybody ought to be familiar with, but in fact very few people are around the country and around the world. The fact is we have first by practice and then codified into legislation a policy in this country that restricts the price paid to organ donors to zero. And as most of you guys would not be surprised, there's no product on earth that if you set the price at zero, you don't have a shortage. So naturally, we have a shortage. And the real tragedy is it's a shortage that at the same time costs the federal government money and kills people. And we now have waiting lists totaling close to 90,000 people who are waiting. And as I said in one of my papers, they're waiting for either an organ or death, whichever comes first. And for 7,000 of them a year now, death comes first. In the last 4 years, we've killed 6,000 to 7,000 people, and then going on back, fewer people, but a total of probably on the order of 60,000 people now have died because of this shortage, died unnecessarily, because the shortage is unnecessary. So I've been doing research in this area for, I hate to think, because I'm always shocked at how long it is now, but it's about 15 years. And Mark, how long do I have, by the way?
About 45 minutes.
Okay, so finish up by 1:15. Okay. Just as a personal note, intersection of events, I have a background in industrial organization, which is the study of markets and how markets work or don't work, as the case may be, and regulation and how regulation works or doesn't work, as the case may be. And going all the way back when I was in graduate school, I was told someday I would need a kidney transplant. And lo and behold, the prediction came true, and I went on the waiting list in 1988 and got a kidney transplant, did dialysis for 2 years, got a kidney transplant in 1990. It was a terrible match. I rejected it. Went back on dialysis, dialyzed till 92, had a second transplant. This was a good match, and there's a lot of wood here to knock on, and I'll knock on it. I just celebrate, let's see, the 25th of this month, I'll celebrate my 13th anniversary of having a kidney that works. And I can tell you, I always tell people urinating is a highly underrated activity. Go for a while without doing it, and you'll see what I mean. So that sort of was my interest in this area. It was very personal, and I got very frustrated having to wait 2 years each time for a cadaveric organ to become available, when I knew for a fact there was not indeed a shortage, but a shortage created by this public policy. So I've been preaching about this now for 15 years and writing about it, and I've published, a dozen or more articles in various journals and in the book that Mark mentioned. And I'm still doing, and this is a topic that it's kind of surprising. You think, you write one paper and this is the end of the story, but it's not. It keeps leading to other ideas and so on. So what I want to talk about today is a paper that I just gave early last month at DePaul University in Chicago. They had a conference on commodification of the human body. And they brought together a lot of people with different backgrounds, legal and ethical and frankly some that were just crazy. I don't know what the hell they were. We had a woman there that was characterized herself as a medical anthropologist who has spent the last several years going around the world trying to catch people selling organs and buying organs around the world and trying to get them arrested for that. I believe she views it as God's work. I don't. But anyway, I gave this paper at DePaul, and it's supposed to come out in the DePaul Law Review sometime next year. The topic I wanted to focus on was the ethics. And some of these slides, is it okay to walk around here? some of these slides I don't probably need to point out to you guys, but as I said, the audience here was there was a lot of law students and people without backgrounds in economics at all. So I wanted to start out with just the definition of what a shortage is, and in the process of defining a shortage, to lay claim to certain property rights to knowing something about a shortage. The people that write in this area, I've got another paper. These people don't even understand what a shortage is. They keep telling themselves and other people that the shortage is the number of people on the waiting list. That's not the shortage. That's the backlog that's built up from annual shortages over probably 30 years now. We've had this problem. And so, people on the waiting list die, so they go off the list. We add more people to the list. We transplant some of them, but not as many as were added, and so the waiting lists go up each year. So I try to explain that a shortage is a flow. It's not a stock. And because of the definition of a shortage as a excess of the quantity demanded over the quantity supplied at a given price, it is a subject about which economists have something to say. We do understand supply and demand if we don't understand anything else. And so the obvious solution to the shortage is to allow the price to rise to its equilibrium level. In other words, repeal the 1984, and of course, as all acts are always titled 180 degrees opposite of what their effect is, the title of the act is the National Organ Transplant Act. And of course, it's the Anti-Transplant Act. And there have been a few economists written on this subject. There haven't been a lot. A fellow named Brahms, who was at Maryland years ago, wrote about it. Gary Becker has written op-ed in the Wall Street Journal. Richard Epstein, who's a lawyer economist at Chicago. A couple of guys at Boise. Is it Boise State? Yeah, Boise State in Idaho wrote a couple of papers. And then in addition to that, it's pretty much me and some of my colleagues here at Auburn have written papers on this. But the point of this is the shortage is caused by the legal ban on donor payments. And it can be resolved by eliminating that ban. Now, what has happened and is what has prevented that obvious solution from being implemented over the years have been a set of alleged ethical objections to paying organ donors. And I'm going to get to that in just a second, what these objections are. But before I do that, I want to state clearly what is and what is not being proposed, at least by me. And because in many instances, people make arguments against, of course, what you're proposing by mischaracterizing what it is you're proposing to make it easier to criticize. All that's being proposed is a small change in the way we currently do things. And I really don't have enough time to go into in any detail the way organs are collected today. But there's a very small set of deaths that are potential organ donors. Death has to occur under a very particular set of circumstances. The person has to be brain dead most of the time. All their organs have to be functioning. They have to be free of infection, which is a strong constraint because a lot of people die of pneumonia and things like that. Cancer, can't use the organs. So there's only about between 1 and 2% of all deaths in the United States are potential organ donors. And what happens is we have these organ procurement organizations. There are approximately 60 of them in the United States. Here's an additional reason we have an organ shortage. Each of them is assigned their own exclusive territory. So they're a monopsonist. And they're all non-profit. So we have non-profit monopsonists collecting organs under the constraint that they pay a zero price for them. Now, if you were to try to imagine a system that was better guaranteed to generate a shortage, I don't think you could do it. And so that's how they're collected now. And what happens is there'll be a death. The hospital notifies the organ procurement organization. They send an organ procurement officer to the hospital. They meet with the family after the person has been declared dead and try to coax and cajole in a nice way the family into donating the organs. They are successful about half the time. So about half of the potential donors donate, and those are the donors that are identified. Now there's a lot of other situations in which there would have been a potential organ donor had the attending physician taken appropriate care of the patient when they died. Not that he let them die, but that he did not put them on the respirator and this kind of thing. Let the blood pressure drop, then the organs are no good. So there's a number of situations like that where a potential organ donor does not get identified. Okay, so what we're proposing is a small change. Right now, this is what I'm proposing, a small change where we leave the system as it is, and all we do is we allow the organ procurement officer, when they approach the family, to go through the same spiel they go through now. This is a terrible tragedy in your family, and our heart goes out to you. And all they do now is they say you have the opportunity to make a tragic event into something good. A lot of people can benefit from these organs. And now we would say, and in addition, we're prepared to pay you a death benefit of, I don't know, $1,000 to $5,000, in my opinion, would clear the market. So we're not talking about a lot of money per donor. And remember, each cadaveric donor yields, I think the average is about 3.7 organs. They won't be able to use all of them in all cases. Some of them get rejected for various reasons. But you got 2 kidneys, 2 lungs, heart, liver, pancreas. Okay, so there's 7 organs solid organs that get transplanted. So that's all I'm proposing right now. And my idea basically is sort of to confide in this group is that if we can just take that little step, that the practice of receiving payment for the agreement to donate will become ingrained, people will expect it, and we can then relax the barriers to entry into this industry and frankly get for-profit firms competing with each other for these things. And I'll tell you, when you tell people that are not economists that, it scares the hell out of them. They immediately envision car salesmen in white belts standing by the bedside, bidding with the family. And what I always try to tell them is, no. Think of the funeral business. The funeral industry is a profit-maximizing private set of companies. If they go around acting like that, they'll go bankrupt. They know what's required. A little decorum and some concern for the family and that kind of thing is the only way to make profits in the business, and so that's what will happen. But right now, all I'm talking about is adding a financial incentive to the current situation, and I believe that will evolve into a true market for cadaveric donors. The other thing is, to keep from scaring people off so much, I always say what we're not proposing. We're not proposing paying living donors. That was why that act got passed in 1984, there's a physician in Virginia that started a corporation to broker organs. And guess where he went for the organs? Where would you go to advertise if you wanted to pay, say, somebody $30,000 for a kidney? He went to college campuses. And he had lots of takers. And the surgeons and the AMA were just absolutely offended and went to Congress and got this act passed. It was living donors. But the act applies to both living and cadaveric. So what we're proposing is payment, not payment to living donors, but payment to cadaveric. And I always point out to people, if you're opposed to the use of living donors, and of course you're opposed to black market activities in India and Turkey and Brazil and South Africa, if you're opposed to that, then you ought to favor payment for cadaveric. In my opinion, I think that the payment for cadaveric organs is going to be so low, it'll drive out the market for living organs. Pretty much. There will still be some living donors, transplants done for kidneys because they work better in the long term. But part of that is due to the shortage as well. And I don't really have time to go into that. The other thing is, living donors are not going to solve the shortage for hearts and livers. Okay? So you're going to have to do something about the shortage to solve that problem with cadaveric donors. Last thing is we're not talking about selling these, putting them up for bid to the patients. Right now what happens is once the organ is acquired, all the costs of the acquisition are paid for under what's called the end-stage renal disease program. I don't have a lot of time to go into this either. That program was passed in '76, I want to say. And of course, you can guess why it was passed. A senator had a relative on dialysis. So, end-stage renal disease program gets passed. It's part of Medicare. The original budget was $300 and something million. It's now over $8 billion. They pay for all dialysis costs. They pay for all renal transplants. They pay for heart, liver, and lung transplants for people that can't afford it now. They pay for this is really good. They'll pay for the immunosuppressive drugs following the transplant for 3 years. And then they cut them off. And they used to cut them off after 1 year. So this was a compromise. Now, what happens? Poor people don't have insurance, quit taking their medications. They reject the organ. They go back on dialysis. Dialysis costs, I think, about $40,000 a year to keep somebody alive on dialysis. Kidney transplant, one-time expenditure about $60,000 to $80,000. Okay, so the transplant is much more cost effective. The immunosuppressive drugs are maybe $10,000, $12,000 a year. So it's much cheaper to transplant. But that's what they do. So that's how things are done now. Or not done. So, shortly after the law was passed, in fact, at the time the law was passed, Ron Paul, who was then a senator from, was it New Mexico? Was he the senator from New Mexico? Texas, Ron Paul? He got up during the hearings and said, if you want people waiting in line for organs like they wait in line for gasoline, pass this legislation. Well, they did. In fact, I think he was the only one that voted against it. So, since then, and even before the law was passed, people have argued, economists primarily, have argued for having markets for organs and on the buying side, not on the selling side, buying the organs from donors, having more than to distribute. And the way they're distributed now, I won't go into, but it's distributed on non-price terms. It's basically how sick you are and how long you've been on the list and blah, blah, blah. But what happened was, when people started proposing paying organ donors, people opposed it. And they came up with this sort of litany of just plain loony, some of them. Just absolutely stupid so-called ethical arguments. There's a really good paper on these by a philosopher named Janet Radcliffe Richards. It was published in the Journal of Medicine and Philosophy, which I had never heard of, but it's a wonderful article. It is a real philosopher writing in just plain talk. And I end up quoting her quite a bit in the book. But in reference to these arguments, she said, quote, people do not rely on arguments this bad unless they're badly in need of an argument. And that really characterizes these things. But this is the list of the so-called ethical arguments. Well, 6 is probably economics. The rest are more or less ethical arguments. And I don't have time to really go through them in detail, but let me just say, number one, argument. I remember years ago on Donahue, he had the talk show. He brought this up. And he said, oh, well, it's just ridiculous to even propose that people would pay donors because then only the fat cats could afford organ transplants. You know, as though poor people could afford organ transplants now. They can't. And that's why the government pays for them. And as though the price of the organs would be, you know, some huge number, which it's not. And as though the patients would have to pay for it, which they would not. So all of these arguments just fall apart on any kind of close inspection whatsoever. There have even, look at number 4, black market sales. There have even been people write in the literature that we should not allow paying organ donors because it would lead to black market sales. if that isn't a perversion of logic, I don't know one. And so on. The last one was what this conference was on, was commodification of the human body. Here's the argument. We can't allow organ sales because it would commodify the human body and somehow reduce the value of your humanity to you. And I've pondered over this one for I don't know how long. And I have a set of responses to that. But I said, okay, what I'm going to do, and with Professor Beard, we said, okay, let's just take for a moment this argument as though it were in fact a serious argument. What's the economics? The economics is an externality. That somehow, if I buy an organ, if I pay Mark to agree to donate the organ of somebody that's deceased, that somehow that insults a non-participant in the transaction. John is now insulted, and his value of his, quote, self is somehow reduced from this transaction that he was not a party to. So it's an external effect. And so said, okay, let's treat it as that. Let's say that it is, in fact, something that does occur, and let's say that it is a negative externality, a third-party effect. And so this just describes that externality. Voluntary exchange between parties transaction lowers the utility of others who are not participants. Okay, if we do that, then we say, okay, under what conditions would that effect warrant a continuation of the ban on paying organ donors? And the answer is the value of that externality would have to exceed the direct benefits generated from paying organ donors. And not only that, and that's what we're going to focus on, but importantly, keep in mind also that the transplant itself generates externalities. The families of these poor people who are waiting to die experience tremendous, joy when they get a transplant. And these people, and this is one of the interesting things I think about transplants. A lot of the medical technology today sort of keeps you alive, but you wish it wouldn't. Really lowers the quality of life. Transplants are not like that. When transplants are successful, I won't say you return to your former health entirely, but you are to a great extent. A lot of people are able to go back to work where they were not able to work on dialysis or whatever. So it's necessary then, if this argument is to warrant a ban on payments, it's necessary that the value of that externality exceed the direct benefits. So what we try to do in the paper is to estimate roughly, very roughly, and extremely conservatively what those benefits might be in terms of social welfare. And the point here is, I'm not an ethicist. I haven't studied ethics, and so I'm reluctant to get into ethical debates with people who have, but I think that an ethical choice cannot be made if you ignore the consequences of that choice, the real consequences of that choice. And the real consequences here, of course, are you're killing people. So it's very difficult to imagine. So what we do, and this is the part where some economists get excited because we're going to do a simulation model and use some real data and bring this to bear. And some economists throw up their hands and say, well, you're stupid and this is a waste of time. But we're going to look at some real data here. We're going to look at kidneys. So we're going to limit it. This is one thing, when you do this, you quickly learn organs are not substitutes, right? You can't substitute a kidney for a heart. They are, in fact, separate markets. And so we're going to look at kidneys because they are the largest component of the organ shortage. And you can see here the number. Well, you can't. I don't have the whole thing on the graph on the overhead there, but the number of people on the waiting list has gone up from just under 30,000 in 1995 to, I think today it's approaching 60,000. Here it goes up to 50 something thousand in 2002. And look at that line. You can see that that's not much of a challenge to forecast that, is it, or to model what's going on. I mean, that's pretty much going straight line upward. And that's the waiting list. These are the people. And then we say, okay, what is the process? Well, let me give you one other number here that's kind of interesting, and that is the cadaver kidney transplants that are done as a percent of the transplant, as a percent of the waiting list. And what's happened is one of the side effects of this shortage is, of course, people die. Another side effect is we're transplanting more and more and more living donor kidneys. I don't know, has anybody in here had a relative that's had a transplant? I'm not surprised. In my big principles class with 260 students, when I ask that, there's usually about 5 or 6 people will raise their hand. And now, today, the number of donors, now not the number of transplants, because you get 2 kidneys from each cadaver, but the number of donors, living donors now exceed cadaveric donors for kidneys. It's over 50% of the donors now are living donors. And it used to be very small. And I had a transplant surgeon who's at San Francisco Hospital who does pediatric transplants tell me one time, she said, it's a good day when what did she? She said, it's a good day when I don't have to do a living donor transplant. Because you're talking about taking a kidney out of a kid to put in another kid. And so the physician's so-called oath to do no harm is violated. Now, I will say, we've been taking kidneys from people for a long time, going back to the Civil War when they got shot in the kidney. They would take them out. And there have been studies on the long-term health effects. And they're pretty minor. They're pretty minor. It's a fairly safe thing to do, to donate a kidney to somebody. But it's not without risk. There have been probably 20 or so deaths on the operating table. Anytime you put anybody under anesthesia, there's a chance they're going to die. So here's our little model that we have. And of course, this is anytime you work with Randy Beard, there's got to be a model. So this is our model. And here's what we've got. We've got, this is the change in the waiting list. Our data are from 95 to 2002. And we stop at 2002. It's nice because we're going to forecast just one period ahead, 2003, and we've got the data for that. So we see how our forecast does. So we've got an intercept and we got time. This is the deaths on the waiting list. If you look at the deaths, number of deaths on the waiting list each year, it is a virtually constant number of about 6.7%. 6.7% of the people on the list die every year. And that's reasonable, right? As the list gets bigger and bigger and bigger, waiting times get longer and longer and longer, and a certain percent of the people are going to die. So that's deaths. This is the cadaveric donors. Okay? So this is cadaveric kidney donors. You get just under 1.5 kidneys on average for each cadaveric donor. So there's a fair number of cadavers that don't yield 2 kidneys. Okay? For whatever reason. One of them may have a disease, may have cancer on it. Sometimes they don't come with all the plumbing they need. Sometimes they drop them in the floor and step on them. So you don't get 2 from each cadaver. So that's what this is the number of cadavers times, and that comes off the waiting list. And then this is the living donors. And the living donors is virtually, again, a constant as a percent of the waiting list. It's about 12% of the waiting list donate kidney each year. And again, that's pretty expected. I mean, these people on the waiting list have families, right? And as the waiting list gets longer, somebody in the family comes forward and donates a kidney. So, these 2 numbers here, these 2 coefficients, we estimated with OLS. And I've got the results in the paper. I don't think I need to bore you with that. But those were estimated with OLS. These other coefficients here are virtually constants. And so we just use those constants to simplify this as much as possible. And then we have to forecast the number of cadavers. So we run a little simple regression there as a function of time as well. Okay? Let me see, how am I doing? Let me stop a second. Does anybody have any questions on any of this? I should have said before I started, please just raise your hand and ask questions as we go along.
How did the new folks put on the list get into that equation? You may have said it.
Well, what happens, John, is what this says is this is the change in the list.
Okay.
So if time, we're going to add, and time is just going to go 1, 2, 3, 4, 5, through the number of observations. So one more click of time adds that many to the list, plus this many to the list already. And then, of course, you have the transplants that are done, right? Here and here, cadaveric and living transplants. So that comes off the list. And deaths come off the list. So 3 ways to get off the list: transplant, living, transplant, cadaver, or die. But in addition to that, we just have more people getting sick every year, and of course, and of course the aging of the population and that kind of thing is causing the waiting list to go up. Okay? And this paper, by the way, let me just mention, the paper is already written. I've actually sent it. It's supposed to be in the DePaul Law Review, and I was shocked. They had this seminar, and these people showed up without papers or anything, and then I found out that the papers weren't due to the editor of the Law Review until October of this year. And hell, I already had my paper written, so I went ahead and sent it to them. So the paper's available if anybody wants it. Okay. So what we're going to do is we're going to take that little model and we're going to generate a 1 period ahead. That's all. 1 period ahead forecast of what happens to the waiting list. And as part of that forecast, we get what the new waiting list will be 1 period ahead. And this matches very closely to what it actually was. We get a number of deaths. We get transplants, cadaveric and living, in total, of course. The baseline is basically nothing changes, right? All the trends continue the way they're going, and we just forecast 1 period ahead, 2003. Okay? Now, this is where the simulation starts to get very conservative. We said, okay, suppose that paying organ donors, all it does is it keeps the list constant. It eliminates the annual shortage, and therefore there's no change in the waiting list. Now what I think will happen, and I've got another paper on this, I believe what will happen is if we pay organ donors, we'll generate surpluses each year. And we can start whittling this list down. We cannot get rid of these lists in 1 year. And in fact, for kidneys, given there's a fixed number of potential donors out there. We don't know what that number is. There are various estimates of it. And it ranges all the way from 8,000 to 30,000. And it makes a huge difference in your calculations. But using a fairly conservative number for that, I estimate it's probably going to take 10 to 12 years to whittle the kidney list down. Hearts and livers we can whittle down quicker. And the reason for that, of course, is, very sadly, hearts and liver, if you need a transplant, if you don't get one, you die pretty quickly. Kidneys, you stay on dialysis and you can stay alive for a long time. So it's going to take a long time to whittle these lists down for kidneys, not so long for the others. So our assumption about compensating donors, I think, is very conservative. All we assume is there's going to be enough people, additional kidneys become available so that the list will stay the same. All right, so we take the difference, and from this we get a number of additional transplants, and we are going to assume that that proportion of living donors to the waiting list stays the same. So what we're going to do is, relative to the baseline, we're going to save 390 living donor transplants from being done. Okay? But we're not going to value that. We're not going to put any we're not going to try to value that. So again, very, very conservative. Here, these are the cadaver transplants. So these are the additional transplants. Actually, this is what we're going to value here, is the additional transplants. So this is, again, very conservative. And we're going to value these deaths using other people's estimates of value of life and the cost savings due to transplanting somebody that was on dialysis. Okay? And again, we're going to use very conservative figures for that. And here are the figures we use. Transplants, this comes from a British Medical Society study of the cost savings, of course, converted from pounds to dollars. And it's a fairly recent study. And that is a present discounted value over the expected life of the transplant. And transplants don't last forever. The average life expectancy of a transplant keeps going up as the immunosuppressive drugs improve and this and that and the other. But anyway, this is what the estimate is of the present discounted value of the cost savings of moving somebody off of dialysis onto transplantation. So that's a cost saving per transplant. And then lives saved. We had 218 lives saved, and this is an extremely conservative, I think, estimate of the value of a life. It's called the VSL, Value of a Statistical Life. A fellow named Phil Held, who's a health economist, has done some work in this area, and Viscusi and some other people have done work in this area. And here's why it is so conservative. The numbers they get are from observed risk-taking behavior in occupations that people take an increased risk of losing their life and will accept how much higher wage rate does it require for them to take a job with a delta increase in the loss of your life. Okay? Now, it's conservative because for those jobs, that delta is pretty small. All right? For a transplant, especially if you're talking hearts and livers, it ain't small. Okay, I was told years ago that if you go out to Stanford and you go to the hospital there, they do a lot of heart transplants there, that if you go visit the motels that surround the hospital, they're full of heart patients waiting for a transplant, and a third of them die every year while they're out there waiting. Okay, so this is a real conservative figure. So anyway, we multiply these, sum this up, and we end up with an annual savings, and this is annual saving, due to paying organ donors of $1.3 billion. This is for kidneys only. It doesn't count the externalities, the values to the families of these people. It's just that, I think, way underestimated value of statistical life, using the assumption that we don't generate surpluses. All we do is stop the shortages and so on. So it's a very conservative figure. It's also a very large figure. So I will conclude with the point of all this, and that is, if we interpret the commodification argument in economic terms, it's a negative externality, then we can apply a fairly traditional cost-benefit analysis to assess the conditions required for that externality to warrant a continuation of the legal ban on cadaveric donors' payments. And we show that the numbers that we're talking about as a practical matter are so large that it is just infeasible to think that the value of that externality would exceed the direct benefits attributable to paying organ donors. So that's what's in this paper. There are, of course, a lot more details if anybody's interested in that. Any questions on any of this? Yeah.
It's just an anecdote, not kind of interesting, but we ran our article, and I forget who wrote it, it's just on the website.
Yeah, I remember that.
It's just called,
Mark, didn't you do that? Did you do that?
they called it something like, your kidneys. It's called something like sell your kidneys.
Yeah.
And, unfortunately, when you Google up sell your kidneys, it's one of the first things that comes up. So hardly a week goes by, and we don't get phone calls.
Yeah, I remember y'all had to put out some kind of disclaimer or something to try to...
we had to put it up at the top of the article.
There are a lot of people out there that are happy to sell kidneys, absolutely. And who was the young German fellow that was here? Yeah, Thomas. He came over and talked to me one day, and I know he's gone back now, and I emailed him. I read this, and then I lost the site. There was an ethics conference held in Munich, Germany, and it was in, I think, December of 2002. I want to say it may have been 3. And at the end, and this Janet Radcliffe Richards was there, and a lot of these ethicists. And to their credit, at the end of the seminar, at the end of this thing, they took a vote. And they said, all right, how many people here think it's unethical to pay organ donors? And the vote was 30-4. That number stuck in my mind. 30-4, that there is absolutely nothing wrong ethically with paying organ donors. What's happening in this business right now last year, there was a bill in Congress, Bob Greenwood in the House and Bill Frist in the Senate, who's a heart surgeon, had bills proposed. They got killed in committee. They got killed by Kennedy. And they got killed by Kennedy because of a guy named Delmonico, Francis Delmonico, who's a transplant surgeon at UMass, or maybe General in Boston. This guy is opposed to paying organ donors. And these guys get on their high horse, and they are so adamant and so vocal, and he's traveling all over the world. I don't know when the hell he does transplants, but he's traveling all over the world saying it's just totally unethical to pay organ donors. I'm starting to attack the guy now in some of the stuff I've written. The last paper I wrote, I've got a footnote in there. He wrote, and this just really fried me, he wrote in one of his papers that it would be unethical, that paying organ donors would, quote, jeopardize the nobility of the medical profession. And so I've got a footnote in the paper, and I quote him, and then I said, well, that's certainly worth 6,000 lives a year. And then I said, he doesn't explain why paying organ donors jeopardizes it, but paying physicians doesn't.
Yeah.
And so I'm starting to attack this guy, and I told the doctor I see here that I had thought about writing the guy a letter and saying, in the history, the most successful serial killer killed less than 100 people, but you're killing 6,000 every year. Congratulations, you son of a bitch.
Dave, when you talk about this commodification angle on this, and, if these people really understand the argument, you're saying one system kills lots of people.
Yeah.
And the live donations, I've heard that people say that living people who've given kidneys is the most painful thing they've ever experienced in their lives.
No, not today. They do. In fact, a lot of them they can do laparoscopic. They can remove the kidney.
You still have death on one side, and on the other side, let's just grant that that's demeaning to life.
Yeah.
Or that somehow harms.
That's what we're saying in this paper. Let's say that. I don't believe it, but let's say it.
But I mean,
how do they win the argument? I don't know how they win the argument, and I'll tell you something interesting. I get calls from people. I did when the book came out. We did radio shows all across the country and everything. I got calls from people, and I had a call about a month ago from the woman at AEI that edited that book. Real nice woman and really good editor. She said, I've got a friend in San Francisco, and said she's been on dialysis 3 years. And she said, I sent her a copy of your book. She'd like to talk to you. I said, all right. And she said, now, her name is Fireman. Maybe I shouldn't say this. Her name is Fireman, and she's of Fireman Insurance Corporation. And so I called her up, and I said, well, the first thing is, I said, how many waiting lists are you on? She said, well, I didn't know you could get on more than one. I said, well, they won't tell you that because they think it's unethical for you to get on. I said, I was on 3. No, I was on 4. I was on the waiting list at Birmingham, Emory, Minnesota, and Pittsburgh. The reason Birmingham, Pittsburgh, and Minnesota are 3 of the very top kidney transplant centers in the country. That's one thing we can be proud of in Alabama. We've got a really good transplant program. And of course, Emory I got on because it was close. And I said, I would have been on more than that, but I was running out of blood. I had to send each one of them 8 tubes of blood every month. And I said, hell, if I'd had more blood, I'd have been on 20 lists, but I couldn't get on 20. But I said, yeah, get on some other lists. It'll shorten your waiting time. But we talked and everything, and then she left me a message on the phone and said, well, maybe we could do a paper on the politics of organ donation. I thought, well, I don't know what I'd say about the politics, but you can do kind of in fact, one of the papers we have, which is the one I wanted to title Rent Seeking in the Graveyard, but I didn't, has to do with kind of the public choice aspect, why physicians and transplant centers might favor a policy that generated a shortage. And of course, the answer is it's like OPEC, right? I mean, if you can cut the output, it's like a cartel. It acts like a cartel. I'm not saying they are a cartel, but it acts as if there were a cartel. And wrote that altruism at one stage of production can serve the purposes of greed at another. But anyway, she proposed we do this paper, and then I got to thinking, and this was a few weeks ago, and the news was just consumed with the Terry Schiavo thing. And I said, damn it to hell. Here we've got a person that's in a vegetative state that's drawn the attention of the president, the federal Congress, a governor, a state legislature, and all these actors and actresses and everything. But we've got 6,000, 7,000 other people who are not in a vegetative state, who are real people dying every year, and nobody pays any attention. And I told her, I said, you know what needs to be done? We need to do a documentary movie. And so I got her interested. She said, that is a great idea. So maybe we're going to do one. And what we need to do, I said, we need at least 3 individuals to follow. One that gets a transplant and starts, working out again, goes to work, does all this, and the family's, one that dies while waiting, and one that's still waiting at the end of the movie. And then, not just that, and visit a dialysis clinic. Go in there with your cameras and show what these people go through in these dialysis clinics. And I've always told people, if you ever get feeling sorry for yourself, go visit a dialysis clinic. And I also say, if you ever think you're making a lot of money, go drive through Buckhead. But anyway, because I drove through Buckhead one time, I said, damn. But anyway, the other thing that needs to be done then is go and interview Gary Becker, Richard Epstein. Come interview me. Cohen, what's his name? Lloyd Cohen at George Mason has written some really good stuff on this. Interview Radcliffe Richards over in London. And then go and talk to that shithead, Francis Delmonico. Go talk to him. Talk to Arthur Kaplan, who I had a debate with him on the radio one day, and I told the moderator, I said, if Mr. Kaplan would just bother to read the literature, he would know that everything he just said has been thoroughly rebutted. But he doesn't. He doesn't read the literature. He shoots from the hip, and they go to him every time. Every time on TV there's any ethical issue, Arthur Kaplan's on there. So anyway, go interview these people, and then give me a chance to come back and say, all right, here's what's wrong with what they just said. But, what you were saying is I think that the best thing you can say, how on earth can somebody defend a policy that kills people and claim to have the moral high ground? It's just insane. But these guys, and They've got the ear of some of the politicians.
What's wrong with paying living donors?
There's not a thing wrong with paying living donors.
You know, now, with the college kids, were they being offered to take their kidney out right then or just to get on the list? Kidney.
Oh, they were going to go in having a nephrectomy.
Oh, okay.
Yeah.
Well, that may not be the price.
And they were going to be paid $30,000-$40,000 for it. Now, that was back in the 80s. And they were lining up.
Why not pay people to become to sign the card?
Well, now that's an interesting question. I didn't go into this here, but we talk about it in the book some. There are all kind of ways to have a market, as we all know. There's futures markets and there's spot markets. And what you're talking about is a futures market. And there are different forms of the futures market. If I say I'm going to pay you to sign your donor card and make that a legally binding thing, I don't think that's going to do much. And the reason is the equilibrium payment for that would be so damn low, I think it would be overwhelmed with the transaction costs. I think the transaction costs would be higher than the price. Here's why. It's way out in the future we're talking about collecting, and the probability of collecting is 1 to 2%. Right? It's only 1 to 2% of the deaths occur under those circumstances. And it's way out in, so by the time you discount for the probability of collecting and you discount for the time, you're talking about $2 or something would be the market value of it. But the other type of futures market is this. You sign a contract that says that we can have your organs, and we're an organ procurement firm, okay, at your death. Now, if you die under circumstances where we collect those organs, then we will pay your estate $5,000. That's fine. That would work. That would help. That would help. But what people are wanting to do now is they're wanting to say, well, I'm the true organ donor. My family shouldn't have any say-so in it whatsoever. Okay? But, my take is this. I try not to tell the market how to work. We've got spot markets and futures markets for everything. Have spot market and future market for this. There's no reason to rule out one or the other. Let the market decide which one's going to do it best.
You looked into the narrow donor marketplace as far as obviously not as scarce, an individual can donate contract. Interesting whether or not there's any kind of competition you play there.
I have not looked into that. I suspect it's probably illegal to compensate people for that. It's illegal today. Now, let me say this. One of the kidney transplant surgeons, to his credit, said if I had to guess, he said between 1.25% of all the transplants I do, he said of the living donor transplants, he said I think the donor got some payment. He said one of them I know drove away in a new car. So, if it's inside a family, how are you going to control whether it's paid or not? Although now I did a radio show just on spring break in Montreal, and a big issue right there was a person showed up at the kidney transplant center with a donor in tow. They wouldn't transplant. They would not. They refused to do the operation because they suspected that the donor was being paid. So they're the damn payment police now. They're not in the business of doing transplants. They're in the business of policing this idiotic policy. Yeah.
Just eyeball the data. It looks like the demand curve is inelastic.
Oh, yeah. Sure. Right.
But for somebody like me who, and it's a pain, but I go do it, get my platelets where you have to sit for 2 hours and all that. I see myself as a very inelastic supplier. I don't think that, they could pay me much to change my behavior, but looking at the data, it appears that the supply side is much more elastic than what my intuition would be.
I think the supply is pretty elastic too, John, and I'll tell you three sources of that. Number one is a couple of them are just theoretical. First of all, we've got a huge excess capacity out there. We don't have to go kill anybody to get more. We are collecting way less than half, probably on the order of 30%. So we could expand it 3 times, before we hit that. And there's a constraint out there, right? But we've got a lot of excess capacity. Second thing is, what's the opportunity cost of donating cadaveric organs? You feed them to the worms. If you donate, you can still have an open casket funeral, and the people there cannot tell. They send this cadaver, they send this person back to the operating room. They open them, they close them. I don't know if they use anesthetic or not, and I don't know if they need to. but they open them and close them and everything, and you can still have an open casket funeral. You can't tell at all, and so the opportunity costs are very low. The third thing is Frank Adams and Andy Barnett and I published a paper in Contemporary Economic Policy a few years ago. We did now. This is really sloppy empirical work. But in the absence of any other kind of data, we did a survey of students at Auburn. So we've got a survey where you shouldn't be doing a survey. You ought to be doing trials. You know, a student sitting in a classroom is not the same thing as a grieving parent or brother or sister or son or daughter sitting in the intensive care waiting lounge. But anyway, we did the best we could do, and we asked the question two different ways to try to get a boundary on the supply price. We said, how much would you accept? What's the minimum amount you would accept to supply the organs of a recently deceased relative? So we're looking at a spot market transaction. And how much would be the maximum amount you would pay to keep us from taking those organs and bury the body intact? And so we kind of get a bound on the supply. And what our estimates indicated, and we used a perfectly inelastic demand, which is probably a pretty reasonable assumption, and we ended up with a market clearing price of, depending on what numbers you use, between $500 and $1,500 per cadaver. That's per cadaver. So per organ, you're talking about a few $100 to clear the market. And we assumed that we were going to replace all living donors and completely solve the shortage. You know, annual shortage.
Well, and that lends to what you were saying. If it's that elastic, you're going to have a surplus.
And all deaths, we were going to replace, we were going to save everybody, eliminate all living transplants and solve the shortage. And the estimates indicated that it is a highly elastic supply. Now people say, well, that's bullshit. You know, it's based on survey and everything. One last thing that I just ran across recently. In Spain, there are a couple of guys at NBER, I'm out of time, at NBER now, that Body and Gay, who've done a study on what's called presumed consent that a lot of people are pushing, and it's used in a lot of European countries. Presumed consent is just what it said. You check in the hospital, we presume it's okay to take your organs if you die, unless you explicitly state otherwise. As it turns out, it operates just about like our system operates. The physicians will still go and ask the family. And to me, that makes sense. I mean, my God, you go out and you tell them, we lost him. Now you're going to add insult to injury and say, oh, and we're taking his organs. We don't care what you say. You're going to talk to the family, and even in these countries that have legally presumed consent, they won't take the organs if the family says no. And of course, part of that, I'm sure, is dead men don't sue, and families do.
Right.
But anyway, Spain, if you look at the countries that have presumed consent, these guys find that they do have a statistically significantly higher rate of collection of cadaveric donors. It's not high enough to solve the shortage. So it doesn't solve the shortage, but it's higher. But then Spain is up here. And all these other, and it's got presumed consent. And if you go to Spain, and I haven't been, but the people that have, so you talk to them, they say, oh, well, we're doing this, we're doing this, we're doing this. Lloyd Cohen was over there, and during a break during the seminar, he found out they're paying donors. They're paying the organ donors. Not a lot. And right now there's a bill in Ohio to pay $500. It can't be legal because of the National Organ Transplant Act. Will trump it, I'm pretty sure. And it's a felony. $50,000 and I think 3 years in jail.